Now that we've named the waves of an EKG, let's talk about some of the other things we can define about a tracing. Here we're going to take some time to talk about two groups of measurements that are relative to the waves we defined last time. Intervals are measurements of time defined by the starts and ends of waves. Segments are the spaces between waves where our concern has more to do with the voltage component, movement up and down, than it has to do with duration. So the ST segment is elevated or depressed, and the QT interval is prolonged or shortened. One of these that we've already talked about is the R to R interval, the time between two R waves. We used this tool before to measure heart rate, and that's the primary use of this measurement. The interval itself can be expressed in milliseconds or decimal seconds if we wanted, but more often than not, we're going to use this in conjunction with the 300 or 1500 rules mentioned before, or as a tool for judging regularity. If the R to R interval stays the same over many beats, the rhythm is regular. Strictly speaking, what R to R time is telling us is the time between ventricular depolarizations. And when everything is going normally, that's going to correspond to everything else. But we've seen in a couple of examples that this isn't always the case. So in addition to the R to R interval, we can also sometimes measure the P to P interval, the rate at which the atria are depolarizing. If these two numbers aren't, for all intents and purposes, identical, the most likely answer is that there's some sort of AV block happening. Atrial signals aren't always getting communicated down to the ventricles in that case. A more common way to accomplish this same principle is by measuring the PR interval, which we'll hit in just a second. One more thing we've seen before is the QRS complex. You can think about this one as an interval if it helps. We can measure the width or time that the QRS complex takes to do its thing, and this is of course going to have a normal range. In adults, we're going to go between 70 and 100 milliseconds as that normal range. So that's anywhere between a little less and a little more than two small boxes. Anything more than 120 milliseconds or three small boxes is what's called a wide QRS complex. And this is a sign of a problem within the ventricles themselves. It's taking energy too long to move within them. Any numbers I'm giving you today are reference values for adults. Children have physically smaller and electrically more efficient hearts than adults do, so all of these intervals are going to be narrower. Eventually, you should be able to know that it's a child's EKG just by a fast glance. The most specific clue, in my opinion, is narrow QRS complexes. One way we can apply this knowledge right away is by using QRS width to identify ectopic complexes. Ectopy is a beat that originates from a non-normal source. It's coming from somewhere other than the normal pacing focus in the heart. We'll hit this stuff in more detail when we start talking about natural pacemaking, but for the moment, this is what's called a PVC, or a premature ventricular complex, and we can tell that because it's significantly wider than its accompanying complexes, and it's occurring out of sequence. It's happening too soon. That's what makes it premature. Looking at the front end of the tracing, we can measure the time it takes from the start of the P wave to the first deflection of the QRS complex. We call this the PR interval, whether the first deflection is a Q wave or an R wave. The normal duration for a PR interval is between 120 and 200 milliseconds, or between 3 and 5 small boxes. So if it's more than one large box, the PR interval is prolonged. The PR interval is giving us a proxy measurement of AV health. Remember, the AV node's job is to provide a pause between atrial and ventricular contraction to allow for the atria to contract and move blood into the ventricles. That pause has to have an appropriate duration for this process to be functional. A prolonged PR interval suggests that the AV node is taking too long to do its job, and that can be a sign of damage to it. A shortened PR interval suggests that the AV node is being bypassed. This example is typical of a patient with a condition called Wolff-Parkinson-White syndrome, where there's an extra wire called an accessory pathway that runs from the atria down to the ventricles, allowing the ventricles to start depolarizing too early. We also have the PR segment. This is the time from the end of the P wave to the first deflection of the QRS complex. This segment gives us an idea of the health of the atria during contraction. Generally, discussion of the movement of the PR segment is reserved for pretty advanced level EKG discussion, But for the moment, we'll say that deviations either above or below the baseline or changes in the slope can indicate damage to the atria. There's a little more to it than that. On the back end, the first thing we're going to look at is the QT interval. This is the time from the first deflection of the QRS complex, whether it's a Q wave or an R wave, to the end of the T wave, and this gives us an idea of the entire ventricular cycle time from start to finish. The QT interval can be affected by a number of electrolyte abnormalities, some congenital issues, and a wide slew of medications, including some that we give. Patients with prolonged QT intervals are at risk for some specific fatal arrhythmias. Unlike pretty much anything else within an individual cardiac cycle, QT interval varies by rate. High heart rates result in QT shortening, and low heart rates result in QT lengthening. To account for this, we have a normalized value called QTc, QT corrected. There are no fewer than 5 formulas for calculating QTc. You can let the monitor do this one for you, and please do. For an example here, we'll do a demonstration using QT interval divided by the square root of the R to R interval. Yeah. In general, a QTc of greater than 450 milliseconds for men or 460 milliseconds for women is considered prolonged. Anything over 500 milliseconds puts the patient at high risk for a dangerous arrhythmia. A fast way to eyeball QTc is to look for the position of the end of the T wave between two QRS complexes. If it falls more than halfway between the two QRS complexes, the patient is likely to have QT prolongation. Again, I have never once in my entire career manually calculated a QTc in the field. I let the monitor do that for me, but I do think it's important for us to understand where that value comes from. Let's come back to this patient from earlier. This is a heart that's really trying to kill itself. Punching out the math, this patient has a prolonged QTc of over 500 milliseconds, meaning that they are at high risk for a PVC like this one, hitting at exactly the incorrect moment and causing a dangerous change in rhythm. Oh, hey, look, there it is. Interestingly, this is actually the same mechanism that causes cardiac arrest in commotio cordis, the phenomenon that leads to the collapse of sports people when they get hit in the chest at the wrong moment. This was the wrong moment. Zap. The last segment we'll talk about today is one of the most important day over day, and this is the ST segment. The ST segment is the period of time between the last movement of the QRS complex, whatever that is, and the beginning of the T wave, and what is being visualized here is the behavior of the ventricles during contraction. In other words, when they're doing their work. Very generally, the ST segment should remain flat and level with the baseline, and deviations away from that suggest functional changes in the ventricular myocardium during contraction. That translates to either ischemia or the death of cells. Changes to the ST segment, and the shape of the T wave as well, are the most reliable way we have of detecting a specific kind of heart attack that happens in the field. The entire genesis of pre-hospital 12-lead EKGs is based on identifying this specific type of heart damage called an ST segment elevation myocardial infarction, or a STEMI. Watch for changes here, and you'll catch some of the most serious problems as they're happening, and you can save a patient's life this way. To summarize, the R to R interval measures the time between two R waves, or two ventricular depolarizations, and gives us a tool for measuring instantaneous heart rate and regularity. We can also measure P to P interval to assess atrial rate and regularity, and compare if there are any differences between the atria and the ventricles. The PR interval is a proxy measurement for the health of the AV node. The PR segment can be used to measure the health of the atria during contraction. The duration of the QRS complex measures the efficiency of the movement of electricity within the ventricles. The QT interval measures the complete time it takes for the ventricles to depolarize and then reset. The ST segment measures the health of the ventricles during contraction, and in combination with the morphology of the T wave, is the strongest indicator we have of ventricular ischemia and cell death.